Hello, my name is Collin Freiberg, and during the COVID-19 pandemic, hospitals around the world began facing ventilator shortages, which led to difficult ethical questions revolving around who should receive the last available ventilator in the age of the coronavirus. Coronavirus is an infection respiratory disease caused by SARS-CoV-2 virus with cold, flu, or pneumonia-like symptoms that can spread easily. The first outbreak of the virus was China on December 12, 2019. The first laboratory identified the case was on January 20th, 2020, after individuals reported cases resulting in 291 deaths. COVID-19 was declared on a pandemic on March 11, 2020. COVID-19 caused severe respiratory illness in individuals of all ages to many critically ill patients that were hospitalized. Families, communities, and healthcare workers were all affected by the horrible pandemic and results of the ventilator being needed to keep patients alive. At the height of COVID-19, hospitals did not have enough ventilators. The demand of ventilators needed to keep patients alive exceeded the supply. The shortage affected critically ill patients, particularly the elderly and those who had underlying conditions. Healthcare workers were also at risk. Families were focused into the devastating fear of, if needed, would their loved one receive a ventilator. The shortage focused on hospitals, doctors, and the government faced the moral question of who should get the last ventilator. Should priority be given to the youngest, the sickest, the one more likely to survive, a healthcare worker? Should the position in society, for example, the president, matter? This decision raised deep ethical concern. In response to the ventilator shortage, emergency planning began, and the nations were encouraged to write their own national and state ventilator allocation guidelines. There was no single federal rule requiring that every hospital have an allocation policy, and hospitals were not legally mandated to adopt a specific protocol. The U.S. did not develop one of the national policies, but encouraged individual states and local governments to write their own. Guidelines written were supposed to be guided by ethical principles of saving most lives, treating people equitable, providing transparent and objective criteria, and support clinicals through triage committees and established frameworks. This left the guidelines focused on scoring systems that patient survival, exclusion versus non-exclusion criteria, priority groups, withdrawal and regulations, triage committees, and pediatric conditions. In the next 5 slides, I will use 10 applied ethical principles to examine the topic of who gets the last ventilator. The principle of personal benefit, the focus on the individual's patients the doctor is evaluating. When applying the principle, the last ventilator should be given to the patient who is most with the highest survival chance. However, using the approach can be ethically controversial between older parents. Patients with chronic illness or patients with low survival probabilities may be at disadvantage, which raises concerns about equality and fairness in access to medical care. The principle of social benefit considers society as a whole, with focusing on saving lives or maximizing the total years of life saved. While this approach may prioritize patients with the highest probability of survival or essential workers who in return save others, it can conflict with every individual equality. When applying the principle of benevolence, the focus should be actively helping critically ill patients by making decisions that improve their overall health. In the case of a ventilator shortage, giving the patient who would need it the most of whose life is most likely to be saved seems ethical. However, some may view it as non-ethical if it results in other patients being denied care. Using the principle of harm, decisions should aim to minimize suffering and prevent unnecessary harm. This decision would be ethical if the ventilator is given to the patient who would worsen rapidly throughout treatment. However, it would consider unethical if giving ventilator causes indirect harm of who's not chosen. The principle of autonomy says it's ethical to respect patients' right to make their own medical decisions. It may be viewed as non-ethical if a patient wants a ventilator but is not choosing to receive. Applying to the principle of paternalism means that healthcare providers should be decisions they believe in the patient's best interest when they cannot do it themselves. In crisis situations, paternalism may override patient choice due to a healthcare providers having to make decisions for a patient as to if they will receive a ventilator. This may be seen as unethical to some because ultimately ventilator decision lies in the hands of medical professional instead of a patient. The principle of justice requires fairness and non-discrimination. When determining the allocation of ventilators, triage decisions and allocation guidelines should not be based on disability, social worth, socioeconomic status, disability, or race. The principle of rights acknowledge a person's right to life. A ventilator allocation guidelines should be transparent and applied consistently. Every individual has basic rights and health care and life. Limited ventilators challenge how to fill those rights. The principle of honesty requires healthcare workers being honest and patients' families about the ventilator allocations, making it ethical as doctors are upfront with the families and patients and the patient themselves. According to the principle of lawfulness, the decision as to who gets the last ventilator ethical as long as guidelines, rules, and protocols are followed, ensuring they are consistent, fair, and not biased. It could be viewed as unethical if the rules are not fair, consistent, or biased. Applying principle of lawfulness, the decision should follow the medical guidelines of hospital policies. There's not a perfect moral answer to who should get the last ventilator. Ethical decisions are made requiring balancing and applied ethic principles. The overall goal should be to save the most life as maximizing the benefit of the ventilator while also treating every patient with fairness, compassion, respect, dignity during a heartbreaking, difficult decision. After thoroughly examining the patient issue when applying the applied ethic principles, my stance on who should get the last ventilator in the age of the coronavirus is described as following. According to the principle of benevolence and social benefit, it should be permitted to provide limited priority of ventilator allocations to frontline healthcare workers because they are essential to treating others. Therefore, prioritizing them in crisis outbreaks can save numerous lives. According to the principles of personal benefit, paternalism, harm, honesty, lawfulness, justice, and rights, it should be forbidden to allocate ventilators based on sex, political influence, race, wealth, and celebrity status. There should be pre-established medical guidelines and triage protocols that are the same for every state where ventilators are required to be allocated based on their clear, fairness, consistent, and non-biased set in place guidelines used to evaluate patients based on severity of illness, survival probability, and likelihood to recover treatment, supporting the principles of benefit, paternalism, social benefit, benevolence, honesty, justice, and rights. It is difficult to fully apply the principle of harm in the situation where there are two patients who need the ventilator. Unfortunately, one patient will not receive treatment. Although harm can be eliminated, healthcare workers should be carefully accessed to patients following strict fair allocations guidelines, minimizing the harm of patients as much as possible. Therefore, it is permitted to give the ventilator to the patient who has the best chance of survival. The COVID-19 pandemic revealed many ethical challenges for healthcare workers. Ventilator allocation without federal guidelines required moral decision-making among hospitals and physicians, with many hospitals not having allocation guidelines and protocols in place. It is imperative that federal agencies are more prepared for possible future pandemics by having pre-established ventilator allocation guidelines and protocols that are the same for every state, that are placed and established based on the application of ethical principles. This listed URL address contains websites along the URLs of our class discussions that I use to gather information through thoroughly understanding the issue and come to my stance on it. I have listed the URL address and the websites I've got my pictures from.